The Confidence Doc podcast is brought to you by My Evergreen Med Spa. Located in Houston in the Woodlands, My Evergreen Med Spa brings to you the latest aesthetic treatments in the most luxurious environment. Remember, My Evergreen Med Spa, it's me time elevated. Welcome back to the Confidence Doc podcast. I'm Dr. Rukmini Rednam. I'm a board-certified plastic surgeon in the Houston, Texas area with my Houston surgeons. And today we have a guest who is all the way in North Carolina. She joins us as she is on faculty at Duke University. Please welcome Dr. Rebecca Knackstedt. Correct?
Thanks so much for having me. It is correct, yes. Thank you so much for having me.
Thank you for being on the show. So tell our listeners a little bit about your pathway, how you became a plastic surgeon.
Sure. Yeah. So I started doing basic science research when I was in middle school, and I always thought that I was going to become a scientist. And then kind of to rule out medicine, I went on a medical mission trip when I was in college and really just fell in love with the idea of taking care of people. So I did a combined MD PhD, and I've had my PhD focusing on vitamin D. And during med school, I was convinced that I was going to hate surgery. So I chose plastic surgery because I very incorrectly assumed that plastic surgery would be the easiest rotation and the least bloody. And I was very, very wrong. And then I really just fell in love with it. I still distinctly remember my first immediate breast reconstruction case. It was just such a game changer for me. I thought, isn't it amazing that we can restore this femininity and sense of self-confidence for women? And after that, I just decided to go full throttle plastic surgery. So I did a integrated plastic surgery residency at Cleveland Clinic, did a extra year there, fellowship for microsurgery, and now I've been at Duke for the past 2.5 years.
Wow, that's really funny. So you were like trying to do everything to make yourself not like it. And that's how we end up here.
Exactly.
So do you have an area that you specialize in?
My practice is mainly breast reconstruction. I do both implant-based and microsurgical breast reconstruction. And then I do a fair amount of gender cases, cosmetic, and just kind of whatever comes in when I'm on call.
Very cool. And, you know, a lot of people understand private practice, plastic surgery, we think of aesthetics, cosmetics. Can you explain a little bit about what it means to be an academic plastic surgeon?
Absolutely. So academic plastic surgery is really different than private practice in that most, if not almost all of my practice is reconstruction. So it's patients who have insurance, not that they're paying cash for an elective procedure. Now, some of us do a fair amount of elective surgery as well, but the majority of it is focused on reconstruction. And being at a large academic center like Duke, that's also a trauma center, we really get some pretty interesting and complex cases in addition to our normal scope of practice.
Mm-hmm. What's one of the most interesting cases you can recall offhand?
By far and away, when I was at Cleveland Clinic, we did one of the face transplants. And as a resident, I had the opportunity to observe for 26 hours in a row. That was by far the coolest case I've ever seen. Nothing's even come close.
I'm a little jealous. That's one thing that I always was like, there's certain things. I always wanted to see a hemicorporectomy, which I did get to see that. And I always wanted to be able to be part of that in some little way, even if it was observing. So that's really cool because that is such a life-changing, I should say, procedure.
Absolutely. And it was so cool. National Geographic was there and taking pictures during the surgery. It was amazing.
We do really cool stuff as a plastic surgeon in training and then even afterwards.
We do. Yes, we do.
So I know you have a very special interest in not just the procedures themselves, but also in how people recover, right? And I don't think very much emphasis is put on that anywhere as much as the technical portions of what we learn in our residency.
Yeah, absolutely. I always thought that I was going to be some type of nutrition scientist. And when I went to residency, I kind of just gave up nutrition. It was in the back of my mind. I knew that it was somehow impacting patients, but just kind of forgot about it. But then as I became more of a senior resident and I was spending time in clinic, I saw that patients were asking surgeons, what can I do before surgery? What's going to help my recovery, optimize my outcomes? And there really weren't great answers because, as you know, we're not taught this in medical school. We're not
Hmm.
taught this in residency. And I had a solid background with my PhD, but I decided to really get more formal training. So I became certified in functional medicine. And through that, really had my eyes open to the alternative field of medicine, if you will, things that we don't often think about as surgeons. And I tell my patients now that I now view surgery as kind of a marathon.
Hmm.
You can run a marathon without preparing, but it's going to be miserable. And just, you can have a surgery
Very.
without preparing, very miserable.
Yeah.
But the more work that you can put in before by optimizing nutrition and stress and anxiety and sleep, it's really just going to make your recovery smoother and hopefully even decrease your chance of having complications.
So explain to people what functional medicine is. It's a term you hear a lot more, but again, not something that gets a lot of like publicity and a lot of education about it.
Absolutely. And it can make it very confusing for the consumer trying to figure out who's a reputable person to get medical advice from. So, functional medicine is really looking at fixing health conditions by addressing the roots of the problem. So, as opposed to just putting a patient on a diabetes medication, it's addressing why that person got to the point at which they are and what lifestyle interventions can we do to help them with their recovery and optimizing their health. So it really does focus on lifestyle interventions, things like nutrition, exercise, stress, and anxiety. What's really confusing, though, to patients is that a lot of people can become functional medicine providers. So it's not just MDs, it's chiropractors, it's even acupuncturists. So I always think it's important to, if you're seeing a functional medicine provider, look at what their background training was, because that really was their foundational training and can influence what their scope of practice is.
Absolutely. And you're right. There's like a vast degree of people that are functional medicine. And I think at its core, it's wonderful because you were really looking at the whole individual. You're not as focused, which can happen, especially in Western medicine. We can get very, very focused on one thing. But you're right. We're all shaped by our backgrounds in education. And so if you have somebody who doesn't know as many modalities of treatment, then they're only going to be able to do something very narrow with having that functional medicine additional education.
Absolutely.
So, because you've put this extra emphasis, and not enough plastic surgeons, in my opinion, do yet. I think we're moving towards this. What do you like when you have someone that comes in, for example, a breast cancer patient? What have you been able to institute that like has been working for you?
Yeah, when I was early in my practice and wasn't busy, I had all the time in the world to talk to every breast cancer patient about all the things we just talked about, especially those patients who were coming off of neoadjuvant chemo and really needed help getting back to their baseline health even before they had surgery. And then I ran out of time. So the way that I approach patients now is I have handouts that I give to my patients that are some evidence-based things that they can institute before surgery, even the day of surgery, things they can bring to the hospital to help with their sleep in the hospital. And then that's really what motivated me to start my Instagram channel. Because for me and my patients, it's always a one-to-one. But when I can reach more patients through social media and meeting patients where they're at, I think that's the way that you can spread the message the fastest.
Yeah, I agree. And I love what social media has been allowing us to do from an education standpoint, because there are so many people out there that would like this. I literally saw, someone who'd already had their reconstruction and unfortunately had a really rough experience, came to me wanting to talk about revisions. And the more we talked, I realized that she'd been given no choices. She'd been given no preparation. And then when things were not just not aesthetically what she wanted, but she was having physical pain, she was told it's good enough. And that kind of thing is just it upsets me because that's not how we have to look at people. We're not just trying to produce a product. We're trying to take care of that person as a whole.
Absolutely. And I think that's one of the things that I love most about being a plastic surgeon is that, especially for implant-based reconstructions, you follow them for their whole lives. So you get to know them and their families and what their hobbies are and how their reconstruction could actually impact their ability to do the things they love. And so I think it's so important when we're determining a treatment plan for a patient that we're considering those things too, and how the surgery that is rebuilding their breast can impact really every aspect of their lives.
Absolutely. Especially since you are on the education side. Do you feel like you are seeing positive changes for teaching new residents and things to start incorporating some of these things?
Yeah, I think that whether my residents like it or not, we discuss my podcast and my Instagram all the time in surgery, and they all know how much I hate Insure and Boost. And it's funny because I see them now. When they get a consult for a lower extremity trauma, they'll ask me like, "Hey, what supplement should we put this patient on while we're preparing for their free flap?" And I love that because, we're teaching the future generation of plastic surgeons. And if we can spread the message that way too, that's going to have such a long lasting impact.
I agree. I agree. Like that's the thing is one person doing it is wonderful, but if we can cause a wave that causes a change, then we're not only going to do better by our patients, we're going to get better results and better outcomes because you're only as good as the body that you're operating on, and you got to make sure it's strong and ready, optimized to
Absolutely.
have the surgery. What are some challenges you feel like are currently existing though in our system for doing these type of things?
The number one thing is insurance. That's the biggest challenge for so many things of how we implement care. But there are studies showing that so many of the interventions that I talk to my patients about, nutrition, exercise, they're better if you implement them before surgery. But insurance won't cover it before surgery. They'll cover Juven, which is arginine and glutamine, after surgery, but not before, even though studies showing that doing it before actually saves money in the long term. So I really do think that in plastic surgery, we need more well done studies to then go to the insurance companies and say, if you just invest a little bit of money in patients before surgery, yes, it's going to improve their experience, which is what we as surgeons want, but it's also going to save you money, or you, the insurance company, which is what the insurance companies want.
And that brings up a point about like the frustration is that so much with insurance lags. So even though we could have good data now, by the time they implement it, could be 2 more years, 3 more years, 5 more years. And so
Exactly.
that's where I always try to tell patients, trust me, that as physicians, we're just as frustrated as you are with insurance. We promise we're not like in the same boat. We're not in the same pot as them. So, what are some things that you're excited about coming up in the future of what plastic surgery?
I think that plastic surgery is such a dynamic specialty. We continue to expand our scope of practice and what we're offering patients, even within breast reconstruction. There's a continual debate of how best to do implant reconstruction, how best to do microsurgical reconstruction that's aesthetically pleasing and functional and gets people back to baseline. I'm really excited about what AI can do for our field. AI is everywhere. And I think that personalized medicine and how AI can help make personalized medicine plans for a patient preparing for surgery, I think that that's probably, I hope, the next wave of things we can implement as surgeons.
I agree. I think AI for surgeons is exciting. I think there are other medical specialties that are very anxious about being replaced by AI. But the
Yes,
one thing that AI can't do is operate on you. So I know
that's
for
very
us it can
true.
be more of an adjunct with it. So what are some things too is because you have such a focus on breast reconstruction, right? A lot of people will come in and they want to know why should I pick implants? Why should I pick autologous tissue using your own body tissue? I think we all have our basic reasonings why, but we all approach it differently. So if someone's coming in or someone's listening right now who's going through breast cancer treatment, what's the best way that you know how to counsel for choices to make one versus the other?
Yeah, that is such a difficult question, and it's hard too because patients will then say, "Well, what would you do?"
I know.
And my answer, I'm sure you too, it's such a personalized decision. I
Hmm.
can't tell you the right thing to do for you at this moment in time. So the biggest message that I reinforce to my patients is that What you choose is not something you have to stick with for the rest of your life. If you do implants and you hate them, or if you have bad radiation contracture, we can do autologous in the future. If you do autologous and it's not voluminous enough for you, we can add implants. So I think that that's a really important point. And then also, their decision about what's best for them might change over time. We're seeing all these young women now with breast cancer who haven't even had children yet. So is doing an abdominally based free flap the best option for them? Probably not, but it might be a really great option when they're 45 and done having children and have a little extra abdominal fat. So I think that it's dynamic for each patient, and it really does change even year to year and where they're at in their just life and journey.
And I love that you mentioned that, because we are seeing younger women, and you're right. We've always talked about, well, belly's great, but not everybody's at that. It's great maybe when you're later in life, and it may not be the initial best option. I had somebody who literally, from a timing standpoint, did not have enough time for the recovery that was required with autologous. So 2 years later, the plan was always that's what she wanted. We did implant based, and we came back 2 years later when it was something she could schedule, and she had less anxiety about it. So you don't have to stick just because you pick one choice now. And I think there's not a lot of misinformation about that, or even not enough education, is that you are allowed to change. Once you've had breast cancer, you are covered for your lifetime for what your reconstructive needs are.
Yeah, that's so true. And, I think that it sometimes surprises me that patients don't know that it's covered by insurance. We just take it for granted that everybody knows that it's covered for their lives. And, people will come in and say, oh, I like the idea of implants, but I can't afford to have surgery every 10 years. So I think that's a really important message to give to patients. But to your point, a lot of patients can't even financially afford to take the time off that's required for autologous reconstruction. If you're providing for your family, but maybe in the future, that's something that would be more financially doable for the patient and their family.
In the U.S., we have 4 approved implant choices out there. I have a lot of patients who will ask me, like, well, is the newest? So the newest to the market is something called Motiva, a new company, not necessarily new for implant production, but new to the U.S. How do you discuss, well, which implants, why you choose certain implants? Because again, this is very personal, but a lot of people just feel so lost and feel like, well, I don't know which one's the best one.
Yeah, that's true. And, you'll have some patients come into clinic that did their research and they're like, I want this brand of implant. I want the extra full profile. They know their CCs, and like, wow, we have a lot of work to do. But I think that being in an academic center, we don't have as many degrees of freedom of what implants we use, because we usually have a consignment with 1, maybe 2 implant providers. It's funny that you mentioned this, because I use Allergan. That's what I grew up with. That's what I was trained in residency with. That's what we have at Duke now. So that's my go-to. And my consult last Friday, her best friend was our mentor rep. So it felt so weird. She brought the mentor rep to clinic, and I was having the discussion. And I was like, oh my gosh, this feels weird to be saying that I use Allergan in front of the mentor rep. But what I said to the patient is that I think that choosing implants and being able to use implants correctly is like speaking a language. And what you want is you want your surgeon to speak the language with which they're most comfortable. And for me, it's Allergan. Could I get a good result with a mentor implant? Sure, but I'm just not as familiar with the sizing and the terminology versus I know Allergan like the back of my hand. So it's, I'm really excited to see what the Motiva results are as we continue to use them in the US, even though we know they've been used all over the world for, a decade and a half. But that is the conversation that I have with my patients.
I think that's a very good way to put it. And I mean, that's even with techniques for a lot of things we do in plastic surgeries. If you're going to see somebody, you feel like this is a person you trust, you want them to do things the way that they can get the best results. And different people may be able to use different techniques to get great results. And I agree, like that, I happen to be a natural person myself. And it's partially because I feel very comfortable with the catalog. And so you want me to use something that I feel good with. And it's not to say that they can't get great results with any of the companies that are available in the U.S. It's just that, you want your surgeon to use the tools that they're used to. So, other things that we can talk about is with concerning breast reconstruction is the use of things like dermal matrices. People also use the term internal bra. What does that mean to you? Like when you're approaching your reconstruction patients?
Yeah, that is another thing that patients come in and they know their terminology. They ask for things like, are you going to use an internal bra? Are you going to use some form of mesh? And I see it being asked all over the social media pages, even, make sure you tell your surgeon to use this brand of mesh for their reconstruction. Um, so I think what's interesting and what I love about plastic surgery is that we are continually evolving. 10 years ago, when I was early in training, almost all reconstructions were done subpectoral. And then as I became more of a senior resident, there was a definite shift to more prepectoral, and very good reasons behind that switch. I personally do all prepectoral reconstruction. It's what I feel like gives me the best reproducible result and gives good patient outcomes. And then the second thing to think about is, what type of mesh do you use? So I love that this is a question that we continue to ask. There's all of these prospective trials coming out looking at, do we need alloderm? Do we need mesh? We were just selected at our institution to be one of the arms looking at, do we need acellular dermal matrix when you're doing a 2-stage reconstruction? I think that as plastic surgeons, and really as any surgeons, we're taught how to do things by our mentors, and we kind of take it as the Bible, like we should do this because we were taught to do it this way. And I think that what I started to do in my practice is just question why. Why am I using alloderm? Why am I using mesh? What is its purpose? And is it serving me in the way that I want it to serve me? Because of that, I stopped using acellular dermal matrix pretty much. But I think that the prospective trials will continue to answer that question so that we can give evidence-based information and allow that to shape our practices.
I agree with you very much on that because I've gone back and forth over the years with what I use, don't use. And just like any other medical specialty, we constantly have to grow and evolve. You don't want a plastic surgeon who's doing everything exactly like how they did in training, because that means they're not doing continuing education. They're not learning and growing.
Mm-hmm. It's so true. I mean, I was listening to the Atlanta Breast Symposium virtually, and leaders of our field in breast surgery disagreeing with each other about what they felt was the best way. And I love that because that means there's no right or wrong answer. It's just, like you said, it's what we do and feel comfortable with. That's going to give the most reproducible result for our patients.
And for our listeners, we go through conferences throughout the year. There's conferences literally going on probably every week somewhere in the world.
It really is.
These are opportunities for us to learn from each other, learn from world leaders and specific techniques. But there is a lot of discussion. You'd be surprised how heated the discussion can get, especially talking about things that would almost seem like, why are they arguing about this?
Yes.
But people feel very strongly about their techniques and their approaches.
Exactly. And it's just what you were saying. Sometimes I think that patients can get frustrated when the medical community in general, changes their mind, if you will. But you want your medical provider to be fluid. You want them to be changing with the new evidence that is coming out. You don't want someone who's stagnant and just doing what they did because it's what their mentors 40 years ago did.
Exactly. And because there are always new amazing things. Like next week you might come out with something that you're like, man, this is brilliant. I don't know why I didn't think of this before. And so we keep and what I love about our community in plastic surgery, we're actually quite small if you compare us to some of the other surgical specialties, but we do share a lot, and we do continually want to encourage everyone to be doing what we think is going to be the latest and greatest for our patients.
Yes, I feel like in the field of plastic surgery, we're all 1 to 2 degrees separated from each other.
Mm-hmm.
Everybody knows everybody within our field. And I think that just also allows for such a good discourse and learning from everyone across the country, both at these conferences and also just word of mouth.
Yeah. So let me ask you, let's shift a little bit with breast reconstruction, but what are your thoughts on neurotization? So meaning for our listeners, this is where we are hooking up nerves when people have mastectomies that's obviously discontinued or cut because of having that mastectomy.
Yeah, that's such a good question. We did a lot of neurotization when I was in residency, and we actually wrote one of the first papers on neurotized implant-based reconstruction. So I was able to see both. I think that there is a lot of good and promising data out there. There's systematic reviews of randomized control trials showing that if you neurotize a patient, it does lead to improved sensory recovery in a more defined way. I think that the challenges that we still have to overcome are what's the best technique? There's all these different sensory nerves. Which sensory nerves do we use? How many do we use? Do we use a nerve graft, conduit, autologous? There's so many questions, so many degrees that we need to address. But then once again, it's going to be insurance. These things are expensive. With a nerve graft being almost $10,000, you put in a nerve graft, alloderm, and an implant, and that breast just costs $30,000. So I think that hopefully, there's so many randomized control trials continuing to go on that I really hope that we have more definitive answers in the next couple of years.
And I think the drive behind all of this is that when we are reconstructing, we were trying to help people feel as normal for them as they can be, right? And so I think we're moving in the positive direction with really understanding neurotization more. But I agree with you; it's kind of a little bit all over right now. We don't really know what the best, most predictable technique is, and is all sensation equal, right? If we get you sensation, is that sensation as like providing you the same that you had before? Is it worthwhile to do that? So I think we have a lot to learn there, but it's another area that I think a lot of people are really exploring.
Yeah, absolutely. And I think the thing that about neurotization or sensate reconstruction that I love the most is the collaboration that it forces between the plastic surgeon and the breast surgeon. It's more than just you making your mark and waiting till they're done with the mastectomy. It's often, guided mastectomies and being there for the lateral dissection. And it just allows for great conversations. And I love the collaboration that it just forces you to have.
I do too. And, we were both recently at the ASRM meeting, the microsurgery meeting. And, I watched somebody talking about neurotization with nipple grafts for trans patients. And it got me really excited. I did my first one and, I'm excited to see how things go. But it was literally when we go to conferences, it's like you see it and you're like, I want to do this now. And you come back and you're all excited for it. So I think that, like I said, it's where what I think has inspired people to do that was starting with the neurotization with breast cancer. And then like, wait a second, there are other places we could be preserving sensation as well.
Absolutely. It's such a field of innovation. What we do is so many different surgeries, but it's a toolbox that you can apply to all those different little niches within plastic surgery.
So tell me a little bit about what's your you said you've been at Duke now for a couple years. What's your plan? Like, what are you hoping that you kind of achieve during your time there?
Yeah, I think, when you're a resident, and you're a fellow, you're building your CV with everything you can do, research and leadership and networking. And then you go into practice and you take boards. And once your boards are over, it's kind of this black hole where what's next? Yeah.
Yeah.
And you don't need that crazy CV with 100 publications anymore. You can if you want to, but you can really focus on what brings you joy. And for me, what has brought me a lot of joy has really been just spreading the message of prehabilitation. I'm not tech savvy, but I, taught myself Instagram, which my residents really make fun of me for being old about. But, I've loved that. I'm editing a book for breast cancer prehabilitation that will be geared towards providers, and it's largely Duke writers. And then I'm also writing a book geared at patients, so different language and different focus. But I just really love, going on podcasts. I've been giving grand rounds about prehabilitation. And I think that once again, like we said, if I do surgery on someone, it helps one person. But if I can influence other people to think about the way that they treat their patients, it's being able to impact so many more people.
I love that. And I'm absolutely all for it. When is your book going to be available?
So our book, Springer is the editor, and our due date is later this year. So I would assume sometime 2026. And I love it because there is some plastic surgery, but but it's almost all non-plastic surgeons. We have medical oncologists and radiation oncologists. We have sleep specialists, anxiety specialists, people who talk about drug cessation and smoking cessation. So I think that it really is that holistic view that really will be applicable to so many different healthcare providers.
That is awesome. This is the direction we need to take things for real, for us to get not just even in plastic surgery, but ideally this keeps sparking more and more people to realize that in everything surgical, we could be doing better for our patients by really helping them from before we even hit the knife to their skin.
Absolutely. And I think that's part of what I enjoy about being in academics. We often have a little bit of protected time when you're in academia to do research or leadership or whatever else brings you that joy. And when you're not as focused on money and RVUs that you might have to be if you're in private practice, it really just gives you a little bit of freedom of exploration and free thinking and thinking creatively about what you could do in your own practice or what ideas you want to explore through doing research in plastic surgery.
And I personally just love seeing badass female plastic surgeons doing these type of things. So we're excited to see what you continue to do with your career and excited to see your book when it comes out. If any of our listeners were interested in learning more or wanted to reach out, come see you, how would the best way for them to find you?
Yeah, so my Instagram handle is at surgical_recovery. I also have my personal one, which is r.Knackstedt, MD, PhD. You can email me. It's easy. It's rebecca.knackstedt@duke.edu. But I love hearing from people. If there's topics that people want me to explore on my podcast, or my Instagram, even if I don't know the answer, I love going into the literature and finding the answers. So I'd love to hear what people want to learn more about.
Well, thank you so much for joining us today. This is great. And like I said, the future is looking bright. We're going in all the right directions. And please, I encourage you to follow Dr. Knackstedt. She has some really awesome content. And the more you're educated about what you're going through, the less stress it is for you and the better I think you recover with that. So Thank you again for joining us today. And thank you thank you all for joining us on the Confident Stock Podcast. Till next time.